First of all, I'd like to express the thanks of my wife and myself to the University Hospital authorities who are acting as hosts, and especially to Nat Nusoro for his kind invitation for us to attend here in person. I regret that considerations of health have meant that it's not practicable for me to fly across, but I take the opportunity of joining you as I do by video. A brief overview of what I'm going to be talking about. It's about the principles of consent and the massive changes that have been effected by the recent Supreme Court case of Montgomery, a case that although it emanates in the United Kingdom, is likely to have major knock-on effects in common law jurisdictions around the world. I'm going to look briefly at the principles of consent, then at informed consent, how much information the doctor has a duty now to convey to the patient, how he should conduct that pre-surgery consultation, and that is a very significant change of emphasis, and finally, of course, how he should record the content of that consultation. There are very considerable changes afoot, and there are going to be massive changes required in the working arrangements of the medical profession. A preliminary word, if I may, about my background. I have mainly been a prosecutor, a criminal practitioner, and in the course of that work have manifestly had to deal with many cases, murder, woundings, manslaughter, inquests, all of which have involved detailed consideration of medical evidence. But apart from that, on the criminal side, for more than 30 years I've taken a special interest in the common law principles and the development of the common law on consent to treatment, particularly as it affects the individual and his right to choose what is and is not done to him, and of course especially to how it affects children. Now that experience has taught me that there's a tension that can exist between doctors and lawyers. Their encounters are often in a setting of confrontation, when battle lines may have already been drawn, entrenched positions taken, and there are various ways in which that can happen. A claim for damages for professional negligence, a coroner's inquest when a hospital is being blamed for the death of a patient, or before a fitness to practice tribunal when the conduct of the doctor is being called into question. As a former health minister so famously said to a Commons Select Committee, the proper place for lawyers in a hospital is on the operating table. And I suspect that that's a sentiment with which some doctors would all readily agree. Now my intention today is to try and bridge that divide, to defuse some of the confrontation and at least lead to a better understanding and cooperation between the two professions and, of course, the patient. It's against that background that I would like to share with you a common law perspective on informed choice in consent to treatment. The theme chosen for me is First Do No Harm, Bloodless Medicine and Surgery as the Modern Ethical Option. It's a challenging and highly topical one. It reflects the starting point for any consideration of the relationship between doctor and patient and the legal and ethical principles of consent that underpin the Hippocratic Oath, and especially the principle primum non nocere. That translates literally as first do no harm, or more freely, above all else, do no harm. Now that concept was picked up and developed by the famous nurse Florence Nightingale, who wrote in 1859 in her seminal Notes on Hospitals, "A hospital should do the sick no harm." Harm in this context can cover a wide range of examples of direct physical harm. They're all fully documented in the medico-legal case law, as well as textbooks and publications with which I suspect you will be well familiar. But harm can extend beyond those obvious examples and into indirect harm, psychological damage as well as physical. Treatment without consent of a kind to which the patient objects and finds repugnant to his conscience is not merely unethical, but equally capable of causing significant damage. In a Canadian case, Mr. Justice Binney, an experienced judge of the Supreme Court of Canada, said, involving a case, it was a case, I beg your pardon, which involved a mature minor, but who chose not to have a blood transfusion, he said this: "Forced medical procedures must be one of the most egregious violations of a person's physical and psychological integrity against the will of an individual." Thus, many authors, doctors and judges agree that coercive treatment of a competent patient is not ethically compatible with the Hippocratic Oath. Now, on consent, the first definitive legal ruling came in a case called Schloendorf in the United States in 1914, now over 100 years ago. And essentially it was restating the Hippocratic principle. The judge was Judge Benjamin Cardozo, and he said this, amongst other things, in the judgment: "Every human being of adult years and sound mind," pausing there, you will see that he addressed the two issues of competence and capacity, "has a right to determine what shall be done with his own body. And a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages." But it's important not to confuse a patient's decision that the doctor personally may think is wrong with a clinical diagnosis of a lack of capacity. Authors writing in the BMJ some 23 years ago dealt with this quite comprehensively. First part reads, "Many medical ethicists have commented wryly on the catch-22, by which patients whose competence is in doubt will be found rational if they accept the doctor's proposal, but incompetent if they reject professional advice." And the authors continue, "This assumes two debatable points: that the doctor is right about what is in the patient's best interests, and that treating the patient, even without the patient's consent, will still help the patient. Such assumptions, in effect, allow practitioners to do whatever they wish to an unresisting patient, irrespective of his true capacity to make decisions or lack of it. It's submitted that such a position is unwarranted when patients may lawfully refuse treatment for reasons which are rational, irrational, or for no reason at all. That is reflected in the Mental Capacity Act in the UK, Act of 2005, which says, amongst other things, a person is not to be treated as unable to make a decision merely because he makes a wrong decision. Now that, of course, begs the question of unwise or wrong in whose opinion, and judged by what standard? In exercising choice in the leading Canadian case on advanced directives, the court said this: regardless of the doctor's opinion, it is the patient who has the final say on whether to undergo the treatment. And a nice little neat saying, the patient has the right to be wrong. Now that case has crossed the Atlantic and been incorporated into UK law. From there it has been cited and followed and adopted by the European Court of Human Rights in Strasbourg, so that it's now applicable law throughout all 47 members of the Convention states. And thus a whole swathe of the Northern Hemisphere, from Vancouver right across to the east coast of Russia at Vladivostok, has now accepted this as the law. Another example is the Code of Practice. The Royal College of Surgeons of England have addressed this matter, and they have specifically directed in a protocol that Jehovah's Witnesses who choose non-blood management on the basis of scriptural values are described in this way. This is a deeply held core value, and they regard a non-consensual transfusion as a gross physical violation. So after that brief introduction, may I turn to consider the scope of capacity to consent. The case of Ree C shows how even a psychiatric patient detained in a special hospital such as Broadmoor may have capacity in certain circumstances to choose his treatment or to choose not to have the treatment. The patient in question developed a gangrenous lower limb, and the medical advice, the surgical advice, was amputation. He declined to have it amputated, and the hospital sought to invoke the mental health laws to circumvent that refusal. But in fact, the judge found that although properly detained in the hospital, on that narrow issue, he did retain capacity to decide, and he refused the hospital leave to carry out the amputation. The patient was aged 69. He was undoubtedly a dangerous schizophrenic. He had stabbed his former girlfriend, and that was why he was detained. And apart from his other psychiatric symptoms, he suffered florid delusions that he was an eminent world-class surgeon of exceptional and outstanding ability. In evidence to the judge, he expressed the grandiose delusions, and I quote, of an international career in medicine, during the course of which he'd never lost a patient. I suspect we're all familiar with some surgeons like that, but far from being compulsorily detained in a psychiatric institution, they're busily engaged in operating theatres around the world and firmly convinced that they too are surgeons of exceptional and outstanding ability. In a case in 2007 challenging the Medical Defence Union over refusal to continue professional indemnity insurance cover, a very experienced High Court judge referred to some such doctors thus: the so-called benign incompetence, long on bedside manner, charm and communication skills, but short on clinical skills. Rest assured that the medical profession is not alone in having benign incompetence in its ranks. We at the bar have our share, and some are even judges. Now, having dealt with that issue of consent, can I deal with this important matter of the progression of the law on the duty of disclosure? The medical case law shows just how definite there has been a progressive yet paradigm shift from medical paternalism on one hand, the old style way of doing things, to patient choice, which is now the law. It's mainly involved a slow but progressive development of the law on how much information the doctor has to disclose to the patient to enable the patient to be fully informed and thus to take an informed decision. Along the way, a number of professional authors have written with discernment on this issue, and I start, if I may, with an article published in the Canadian Bar Journal entitled, "Why Do People Sue Their Doctors?" And this is a longish slide, but I'd like to take time looking at it. First and foremost is the very nature of medical practice itself. In a field of rapid discovery, the accepted treatment of today was risky yesterday and will be obsolete tomorrow. During the period of yesterday, the treatment was new and hazardous, perhaps experimental in the eyes of the court, and few doctors would come to its defence. During the period of tomorrow, it is obsolete, antiquated, proven to be wrong, condemned in the witness box, and accepted as negligent by the court. It is only during the period of today that the treatment is right and proper, and this period is made ever shorter by the rate of discovery. You may think that's a fairly perceptive article to be published in a bar journal. And then in 1982, Dr. Leahy Taylor, who some of you I suspect will know, the very experienced former secretary of the Medical Protection Society, with which I think that some of you may well carry your professional indemnity insurance. In his seminal work, The Doctor and the Law, he expressed the principles with clarity and simplicity. And he said this: "It is an assault to carry out any examination or treatment which involves laying a finger on the patient without consent. Now notably, such consent was not qualified by any requirement for the secondary consent of a relative or proxy. The patient, including a pregnant woman, who has competence and capacity, alone has the right to decide. By 2008, this significant shift to patient choice was legally acknowledged in a case in the United Kingdom, Birch versus University College Hospital Trust, and that's a case I will look at in a little more detail in a moment. So each case was moving, however slowly, towards a duty of full disclosure to the patient and thus truly informed consent. Three cases, I'll mention two of them quite briefly. In Canterbury and Spence, that was a US appellate court decision, the court had to consider the right of the patient to sufficient information being disclosed to him to enable him to reach an intelligent and informed decision. And the court ruled in favour of the patient's right to be properly informed. 8 years later in Canada came the case in the Supreme Court there, Rival and Hughes. A patient underwent surgery that carried a known but undisclosed to her risk of stroke, put at 10%. When that materialised, she claimed successfully against her doctor. But the Australian case is probably the one that is most recent and carries a lot of weight. It's a case of Rogers and Whittaker. Miss Rogers was a teacher. She had very deficient eyesight in one eye, to the extent that she was almost totally dependent for her vision on the sight in the good eye. The contemplated surgery was to the bad eye to try and improve it. And she was not told about the level of risk inherent in that. The literature showed that the risk was 1 in 14,000. By medical standards of that time, not considered a very significant risk. But it was, in fact, I suppose by those standards, what you might call an improbable eventuality. The important point is that the patient asked about risks, but the consultant ducked the question, and she was kept in ignorance. In good faith, she gave consent and the surgery went ahead, but it failed, not only on the bad eye, but she was rendered blind. And had she been properly informed of the risk, she was adamant that she would not have had the operation. Now, interestingly for you ophthalmic surgeons, at trial it was shown that a very substantial body of responsible eye surgeons worldwide, this wasn't just confined to Australia, they had experts from worldwide, said that to that patient it was a material risk that should have been disclosed. The court agreed, and as a matter of law, the doctor, having failed to disclose it, her claim succeeded. In the course of the judgment in Rogers and Whittaker, the court said this: all medical treatment, and I emphasise the all medical treatment is preceded by the patient's choice to undergo it. But the choice is, in reality, meaningless unless it is made on the basis of relevant information and advice. So that was the Australian case. Back in the United Kingdom in 2003, in the Court of Appeal, a case came before Lord Justice Sedley, a wise, humane and experienced judge, a case called Wyatt and Curtis. The court had to consider non-disclosure of a risk of around 1% that chickenpox during pregnancy might result in significant brain damage to the fetus. Significantly, one of the lines of the defence was, she never asked. And in the course of his judgment, Lord Justice Sedley said this: there is something unreal about placing the onus of asking upon a patient who may not know that there is anything to ask about. So, just to summarise so far, you had senior judges in 4 well-respected common law jurisdictions, the US, Canada, Australia and the United Kingdom, coming down firmly in favour of informed consent and the duty to provide the patient with sufficient information to enable the patient to make an informed choice. So the next stage was the judgment in Montgomery in Lanarkshire, and that brings me to the most important case in this presentation. The law was consolidated and reinforced by this judgment, and it now represents the settled law there in the United Kingdom and very persuasive law throughout the world because of the authority of the Supreme Court. May I tell you briefly the facts? The pregnant woman was from a medical family. Her mother and sisters were both GPs. She herself had a BSc in molecular biology. She was an insulin-dependent type 1 diabetic, and that turned out to be one of the most crucial points in the case, a highly significant feature of it. She was only 5 foot tall, of very slight stature, and for the purpose of the obstetricians, of a very narrow pelvis. Almost, you might say, a textbook candidate for serious difficulties in conventional delivery by the birth canal, and so therefore potentially at high risk of the condition known as shoulder dystocia. As you are aware, one consequence of this may be that the umbilical cord becomes trapped and gets compressed. It cuts off the supply of air, and the medical literature shows if that's continued for more than 7 minutes, there are likely to be catastrophic consequences to the baby and even potentially death. In addition to the consequences to the baby, maternal morbidity is also increased. Statistically, in 11% of cases of shoulder dystocia, there is postpartum hemorrhage, and in 3.8%, fourth-degree perineal tears. Now, the treating obstetrician in the Montgomery case failed totally to raise with the patient the possibility of a caesarean section, and she went on to attempt her professionally preferred mode of delivery, normal delivery by the birth canal. A shoulder, not unexpectedly, became wedged with serious difficulties that followed. And I quote from the judgment: "During the 12 minutes between the baby's head appearing and the delivery, the umbilical cord was completely or partially occluded, depriving him of oxygen. The consequence was catastrophic injuries, including cerebral palsy and Erb's palsy, and obviously a significant claim for damages, both for the immediate damage and especially for lifetime care. And in this case, the Supreme Court upheld the mother's claim that she had been denied the proper and adequate information upon which to exercise her undoubted right of informed choice, and gave judgment against the hospital. It's a long judgment, and I've extracted just one part of it that I hope summarizes what the case was really all about. An adult person of sound mind is entitled to decide which, if any, of the available forms of treatment to undergo, and her consent must be obtained before treatment interfering with her bodily integrity is undertaken. The doctor is therefore under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment. And in the context of this discussion and this conference, I put in italics the final words, and of any reasonable alternative or variant treatments. Now, on this point of disclosure, the judgment in Montgomery confirms that there is, of course, the defense of the so-called therapeutic exception. If it is the serious clinical judgment of the treating clinician that the patient is vulnerable, emotionally vulnerable, or psychiatrically vulnerable, that it would be wrong and would be damaging to the patient to make these disclosures to her, then exceptionally the information can be withheld, because it would, in the opinion of the clinicians, it would do more harm than good. But the Supreme Court has said very clearly it cannot provide the basis of the general rule. So this case and the section of the judgment that I've read is in fact compelling support for patient autonomy and informed choice, and it should resound around not just the world of obstetrics, but around medical treatment generally. Well, time will tell, but Montgomery is a decision of considerable authority on informed consent, and it is likely to be followed in other common law jurisdictions, probably including Australia, Canada, Hong Kong, Namibia, New Zealand, South Africa, and hopefully including Nigeria. These countries tend to follow these kind of persuasive judgments. So that is a brief summary of the position in common law jurisdictions of the law. But there's much more to this than just the law. What matters is the practical application of the law. And the key question that the case raises is, by what standard is the provision of information to the patient to be judged? First and foremost, it seems that little weight can now be given to the standard written form of consent. It'll need extensive revising, if only to include some detailed record of what Montgomery refers to as the dialogue. That's in the pre-surgery consultation, the dialogue between consultant and patient. But the second brings into play alternative options in law. And the law in this area is in line with good ethical practice, that the patient has the right to have these facts fully set out and then to make the final choice. So from there I turn to look at the duty to inform of less invasive treatment options. This is just one aspect of the information that needs to be supplied to the patient when there are such options. And firstly, the case of Birch and the University College Hospital, to which I've already referred. This was a case of a catheter angiogram. It was the standard procedure in a world-class specialist neurology unit at Queen Square in London. The treating team needed to exclude the possibility of a potential fatal arterial aneurysm within the skull, and the angiogram was the then standard procedure. It carried a known risk of 1%. Which, as a layman, I must confess to finding somewhat on the low side for a complex procedure that involves inserting a catheter into the femoral artery and then feeding it right up inside the arterial system, right up to inside the skull. Although carried out, and it was conceded by all concerned that the actual procedure was carried out with all due professional skill and care, the risk did in fact materialize. A clot was dislodged and a stroke caused thereby, and the result was significant and permanent impairment of function to a previously healthy and active patient. Just to give you an idea of the scale of the award, the damages were agreed at £621,000 sterling, but liability was disputed and the case went to trial. A very smart legal team for the patient recognised that the claim could not be successfully run in conventional negligence. Instead, they argued successfully that the patient had never been offered the less invasive alternative of an MRI scan, and therefore she had not given properly informed consent. On that basis, the procedure was held by the High Court to be non-consensual, and absent valid consent, liability followed. That meant an award of the damages, which were agreed at £621,000, but also the costs of an 8-day trial with highly paid senior counsel, solicitors, multiple expert witnesses on both sides, probably a conservative estimate of £1 million costs in total. And you might well be forgiven for thinking, well, that's a specialist neurology case. What did it have to do with me? I'm a general surgeon or a cardiac surgeon or orthopedic or whatever my speciality is. Well, the answer is that although on the facts it was indeed a specialist neurology diagnostic case, it established a much wider legal principle, and that I have summarised in this next slide, which I emphasise is not a quote from the judgment, but is my own summary of the effect of the judgment. Where there are alternative treatment options that are either non-invasive or less invasive, it is no longer merely best practice to inform the patient and discuss the relative risks and benefits. There is an actual legal duty to do so, and for the properly informed patient then to make the decision. So the effect of that is that what was formerly merely best practice has now been elevated to an actual legal duty. In the context of our discussion today, the legal principle is equally applicable to the transfusion of donor blood and blood products, an undoubtedly invasive procedure as opposed to non-blood alternatives which are either non-invasive or certainly less invasive. And so after that fairly broad review of the principles, the ethics and the relevant common law, I turn to look at other aspects of the theme under discussion and remind ourselves that what we're considering is bloodless medicine and surgery as the modern ethical option. Firstly then, that takes me straight to consent to non-blood alternatives. I'd like to take a moment to deal specifically with the topic of non-blood management, probably one of the most frequently encountered issues where the patient exercises a choice with which the treating doctor may not personally agree. In emergency admissions, of course, you clinicians have little alternative but to take the patient as you find him, often unconscious and bleeding. But at the same time, on this issue of consent, to comply with any valid written advance directive that the patient may be carrying or is produced, or as in the leading case of Millette, was found in her handbag when she was admitted to hospital. It's important because at common law these are legally binding and must be followed. And notably, no member of the patient's family has the right to override the choice made by the patient, even in the case where there are minor children involved. But turning from the emergency to elective procedures, you do have some time. And I commend to you an article known as the PREVENT study in the 2015 edition of the medical journal Trials. PREVENT is in fact an acronym for preoperative intravenous iron to treat, and the full sentence runs on to treat anemia in a major surgery. It's written by a team of experts in non-blood management, principally from University College Hospital in London, and led by Professor Toby Richards, who is an acknowledged expert in this specialist field. Nat Usora will almost certainly remember him as a top-class speaker at the annual meetings of the European organisation Network for Advancement of Transfusion Alternatives, which itself is known by its acronym of NATA. Their website is well worth a look, by the way. So the better practice in elective procedures, now being implemented in the best units, is to have a pre-operative assessment clinic at least 28 days before the proposed admission for surgery. There are two main reasons for this. First is the question of consent can be addressed and discussed calmly, without pressure of time, and with the opportunity taken to explain properly the proposed procedure, the risks and benefits, the various treatment options, including non-blood management. And the second question is, well, why a minimum of 28 days? The answer is to address anemia and allow for preoperative workup. It's plain common sense to try and ensure that every patient goes down to the operating theatre with as high a level of haemoglobin as can realistically be achieved. Given a Royal College's and the United Kingdom government recommended transfusion threshold of 7 grams per deciliter, the greater the margin preoperatively, the less likely there will be for a perceived blood transfusion. Now, in this context, one cannot just ignore the contaminated blood scandals, which have been the subject of considerable professional writings and have been especially well documented in the United States, in Canada, in France, and even in Ireland. Taking but one example from many, the scandal in Canada cost over 2,000 lives. One detailed review describes it, and I quote, "a shocking, deeply moving, often frightening analysis of the greatest medical scandal in our history." Not surprisingly, it was investigated very thoroughly, a high-powered and efficient commission chaired by a very able High Court Judge Creever. And among the notable evidence given to the commission, it was a very thorough inquiry indeed, was that of a world-class expert who said this: "For almost half a century, clinicians believed that a hemoglobin level of 10 was necessary before subjecting a patient to anesthesia and surgery." Now, the second part of this slide I have put in italics and bold because I think it's important. The etiology of this requirement is cloaked in tradition, shrouded in obscurity, and then this most important sentence, unsubstantiated by clinical or experimental evidence. And of course, for a profession that prides itself on practicing evidence-based medicine, that is a very serious question mark hung over the whole process of blood transfusion from its very start. Now, having discussed that, the one side, and that citation of concern about blood transfusion, may I turn to look at some actual peer-reviewed evidence, and I stress the word evidence, with which some of you may be well familiar, but others perhaps not. 3 articles are of particular relevance. The first reports how the issue of transfusion thresholds or triggers was revisited at a conference of the prestigious Royal College of Physicians now more than 20 years ago, under the headline, "How did we get a magic number for preoperative hematocrit and hemoglobin level?" A report in The Lancet, generally accepted as the voice of the profession in the United Kingdom, said this, and this is another important slide that I've set out in some detail. Despite more than 5 decades of established practice, and you will note that this was written 20 years ago, so it's now 7 decades, doctors still do not agree about precisely when and why they should transfuse red cells and how efficacy can be assessed. One message was clear. The traditional transfusion trigger, that is, the critical hemoglobin value justifying transfusion intervention, needs to be considerably revised. And despite the diversity of views, there was little dissension from the idea that a therapy that costs so much deserved to be put on an altogether more substantial, and this is important, scientific basis. So firstly, it's that lack of any proper scientific basis or evaluation that causes such disquiet, quite apart from the costs consideration. Now, the second article concerned a patient who underwent surgery, having chosen non-blood management and given consent to it on that basis. She sustained an unexpected but major hemorrhage, and she bled down to a hemoglobin of a mere 1.8 grams per deciliter. Now that is, in anybody's language, in the red zone. But nevertheless, she survived, and importantly in this discussion, without blood transfusion. The case was written up, peer-reviewed, which is important, and published in Anesthesia, the professional journal of anaesthetists. It is notable for 3 points. The first is the date, 1987. That's 29 years ago, and there have been huge advances in medical skills and treatment and non-blood management in that time. But they were doing it back in 1987. Secondly, the status of the treating hospital. It was not a designated centre of excellence, such as a university teaching hospital, special levels of consultant staffing, research, funding, equipment and the like, but a straightforward but good district hospital. And the authors who submitted the article and were the treating team very modestly said in the conclusion, she owed her survival to simple intensive care management. Now, thirdly, for many years, as you know, one particular group of patients, for reasons of religious conscience and belief, have not been prepared to accept allogeneic blood under any circumstances. Jehovah's Witnesses are, in practical terms, the only group whose hemoglobin has been allowed to drop below 5 grams without transfusion of donor blood. Obviously, it is quite impractical, probably unethical, and if not actually illegal, to have a conventional, double-blind, controlled study selecting at random, and that's the point, selecting at random 2 groups, those who will be given blood and those who will not. Even the most tolerant of ethics committees is unlikely to be able to approve such a trial. But the experience of the medical profession in treating this known large group, it's now approximately 8.2 million members worldwide, with non-blood management, was professionally evaluated in another peer-reviewed article published in the journal Transfusion back in 1994. And as you'll see from the slide, the title, "What can we learn about the need for transfusion from patients who refuse blood? The experience of Jehovah's Witnesses." There was extensive reporting of survival at levels well below 5 grams. Whilst no patient or clinician would choose unnecessarily to push the boundaries to those levels, and undoubtedly into the red zone, the clinical facts show that survival is possible. And more especially, the overwhelming conclusion has been that there's been no significant effect on morbidity or mortality in treating without blood. Indeed, there is an international move for blood conservation to try and achieve non-blood management as the gold standard. And it's been expressed thus: bloodless surgery has come to represent good practice, and in the future it may well be the accepted standard of care. In fact, it has already become just that throughout the state provision of healthcare in Western Australia, where the entire state has opted for non-blood management. Now that brings me to alternatives. I know that you have speakers lined up to talk in detail about the clinical aspects and techniques of non-blood management, and I would not be so presumptuous as to trespass into their clinical field. But may I just share with you, by way of example, one of a number of cases in which I was professionally involved on behalf of parents who are Jehovah's Witnesses. It concerned an 8-year-old boy. He'd lived for some time with the pain, the disfigurement, and the sheer social embarrassment of a growth on his neck and jaw called a lymphangioma. It was about the size of a large orange and still growing, very unsightly. The growth affected complex cells and tissues, and the leading surgical textbook described the condition as making extirpative surgery extremely difficult and risky. But an outstanding surgeon was willing to cooperate with the parent's choice of non-blood management and to undertake the procedure without blood. Risk managers in the NHS hospital took a different view, and they insisted on obtaining a court order which was duly granted. Now, in our jurisdiction, such orders are granted on the basis that they are permissive declarations that it would be lawful for the procedure to be carried out, including blood. But the ultimate clinical decision still rests with the actual treating team. Technically demanding surgery, rightly described as difficult and risky, was successfully carried out by an exceptionally cooperative team, and the young lad made a full and uneventful recovery. So that is just but one example of many, that highly difficult and risky and complex surgery, because excising a lump of that size in the region of the neck and jaw was extremely demanding surgery, but it can be done. Turning from general surgery of that kind to obstetrics. In the UK and in many other common law jurisdictions, the decision-making rests exclusively with the pregnant woman. In its guidelines, the Royal College of Obstetricians cites the Law Commission, and I quote, "We do not, however, accept that a woman's right to determine the sorts of bodily interference which she will tolerate somehow evaporates as soon as she becomes pregnant." And it adds this: "For the duration of the pregnancy, the woman is the only person who can control what is done to her fetus." The Court of Appeal upheld this principle in robust terms in the well-known St George's Healthcare Trust case, which was something of a fiasco. The court roundly condemned the misuse of the Mental Health Act provisions as a manifest display of medical paternalism and an improper attempt by a hospital to outflank a valid refusal by a patient. And more recently, just a reminder that Lady Hale, in the Montgomery case that we've been talking about in the Supreme Court, reaffirms these principles again in fairly robust terms when she says in the judgment, "Gone are the days when it was thought that on becoming pregnant, a woman lost not only her capacity, but her right to act as a genuinely autonomous human being." That is a compelling statement from such a judge in such a court. A brief word about resources, because resource implications always arise in non-blood management. Common sense suggests that in allocating resources for non-blood management, priority ought to be given to two areas, obstetrics and to neurosurgery. If nothing else, because they are the two classes of case probably presenting both the highest risk, but also, by the medico-legal cases, probably the highest quantum of damages per claim when things go wrong. But remember the wise words of H.G. Wells. In England, we have come to rely on a comfortable time lag of 50 years or a century intervening between the perception that something ought to be done and a serious attempt to do it. That seems to reflect the position in our health service, sadly. And now, if I may, a brief word about children and particularly mature minors. Time does not allow for a detailed discussion, but exactly the same ethical principles apply to the decision-making that properly rests with the parents if the child is below the age of comprehension and capacity to exercise choice. Indeed, it has always been a hallmark of totalitarian regimes, going all the way back to ancient Sparta, and more recently in modern times Nazi Germany and the communist USSR, that the child belonged to the state rather than to the parents. I commend to you an authoritative paper by Len Doyle, a now retired eminent professor of law and medical ethics from the prestigious London teaching hospitals St Bart's and the Royal London, in which he sets out in considerable detail, firstly, his considered professional views on the capacity of even very young children to have real insight into their condition. Secondly, their capacity and indeed right of choice that extends to the right to consent or to choose any particular treatment, even very young children. As you would expect, he cites medical and legal sources in support, some 53 of them. It makes enlightening reading and is a powerful counter to those minded to disregard and override the wishes not only of the parents but of the comprehending child patient. A word about iatrogenic transmission, the doctor's responsibility for passing it on. There is a substantial volume of professional material relating to risks of iatrogenic transmission via blood. Taking but one example, particularly relevant to Africa, a recent June 2016 peer-reviewed article in the Journal of Infectious Diseases reports as follows. Although the exact source and factors leading to the HIV pandemic are unclear, it has been suggested that iatrogenic transmission, such as transfusions and intravenous injections in the hospital, may have contributed to the spread of HIV. Although iatrogenic transmission of HIV is quite low today, the international medical community must remain vigilant in order to protect patients from iatrogenic transmission of emerging infectious diseases such as Ebola. And I would then add to those comments that they would seem to apply equally to the newly emerging threat of the Zika virus. So, if I may, by way of conclusion, if you take nothing else away from this presentation, I hope that you will appreciate just how much a detailed explanation to the patient of risks and benefits does matter, but especially a careful explanation of alternatives that the patient may choose, leading to properly informed consent. It matters to the patient, to the treating team, and to lawyers. The more invasive the procedure, and the more likely the risk of high blood loss, the more important it is to take time to have clear communication, intelligible and patient-friendly explanation of the proposed procedures, the risks and benefits, and especially the available alternatives. And then to ensure that the patient's acknowledgement of the consultation and his or her choices, including risks, benefits, and alternatives, that is, a summary of the so-called Montgomery dialogue, are accurately recorded in the clinical notes and preferably, and for your own safety, countersigned by the patient, dated and witnessed. Finally, may I leave you as doctors, surgeons, nurses and midwives, whatever your speciality, with 2 points to ponder. The first is the law. In California, more than 25 years ago, they changed the law following a high-profile case in which Paul Gann, a 75-year-old, well-respected and long-standing US senator, contracted fatal HIV from a contaminated blood transfusion. In effect, under the act that bears his name, the Paul Gann Blood Safety Act, there's a reversal of the presumption. The risk of allogeneic blood is acknowledged to be so high, even in that affluent society, that the patient there must now opt into and expressly accept the risks rather than opt out. The standard for informed consent is indeed a high one. The second is professional. The director of the Edinburgh and Scotland Blood Transfusion Service is someone who you may think the position of authority indicates that he may not unreasonably be relied on to know what he is talking about. He has said that doctors should carefully ponder the question, if this was myself or my child, would I agree to the transfusion? And another eminent professor said at a medical conference, albeit with anonymity protected by the Chatham House rules, of course, no doctor would have blood. Now that raises in an acute form the ethical issue that if you, the doctor, would not have it, should you be insisting, perhaps simply for reasons of compliance with a questionable hospital policy on risk management, that your patient has it? I hope that as you go away from here and back to your busy daily practices, you will weigh carefully the balance of perceived benefit against potential or actual risk of harm, physical and emotional, in transfusion of allogeneic blood. And that you will not only give very serious consideration to, but accept the ethical position that informed patient choice does matter, and that you should respect and follow the patient's wishes for alternative. I have only scratched the surface today, but there is ample peer-reviewed material that demonstrates clearly the theme of this talk, that bloodless medicine and surgery is the modern ethical option. So may I thank you for the opportunity of presenting this material to you, and I wish you all an enjoyable and instructive conference. Thank you very much.